Neuropathic pain states have a number of other sensory abnormalities that are not found in somatic pain. And this would be dysesthesia, which is basically what I've been talking about. You can substitute the word dysesthesia for deafferentation pain. There is a paresthesia, which is an abnormal sensation. It may not be pleasant, but it is not painful. And then there is hyperesthesia, which may not be painful, but the patient has a heightened sensitivity to some type of stimulus. So neuropathic pain has a wide variation in how it's appreciated. It is more subtle in its manifestations at times, and it is also more forward, more readily appreciated at times than somatic pain. But I do believe that for the vast majority of cases, and there are exceptions, that you will be able to distinguish between somatic and neuropathic pain, even though some of the names that you use to describe it are non-pathognomonic. Do diagnostic nerve blocks provide discriminatory information? Now, my answer may surprise you, but I think that the answer to this question is no. They do not. The premise under which diagnostic nerve blocks operate is the fact that the pathology is in some exact location and that the impulses travel via a unique and consistent pathway, and that relief of pain is due to some type of block of that pathway. Remember I said that the nervous system is extremely dynamic. Well, it has a tendency to get around our local anesthetic. And this is the concept of plasticity, which Henrik will elaborate upon. We have a nerve, and the nerve has a branch, and we have a second nerve. This branch ordinarily does not fire. It is dormant. And then we have some type of injury to this second nerve, and this dormant branch now begins to fire. And therefore, it sets up these type of interconnections. I would propose to you that the anatomy in the textbooks, particularly for the nerves that are involved in your surgery, are idealized. There are multiple interconnections between these nerves. And to attempt to do a block of the genital branch in the inguinal area, to attempt to do a ilioinguinal and iliohypogastric block over at the superior anterior spine is not going to give you the information that you're going to need, and we'll deal with it. Why? Because the nervous system is too diffuse, and the nervous system gets around your blockade. This is a classic example of the nervous system getting around the blockade. If I had cancer, one of the things that you could potentially do to me for pain on this side of the body is, if this is the spinothalamic tract, a neurosurgeon can come and make a lesion in the anterolateral quadrant. This is referred to as a chordotomy. The reason a chordotomy only lasts approximately 6 months is because while there is mainly, as you all remember from medical school, pain is mediated by the spinothalamic tract, which goes to the contralateral side. What they forgot to tell you is that there is also an ipsilateral spinothalamic tract. And if this is no longer functioning, this ipsilateral spinothalamic tract now begins to begin to fire, and the patient has return of pain. This is an excellent example of plasticity. This is an excellent example of why you can make a nerve lesion, and the nervous system will then go ahead and to the next higher order neuron, go ahead and begin that to fire. You make a lesion there, and once again, the nervous system will have the next higher order neuron begin to fire. I mentioned the fact that there are diffuse interconnections, and I mentioned the fact that it is I think, this is an old textbook drawing from about 1900, and the best way to achieve anesthesia in this area is by infiltration. Large volume. Do not attempt to block discriminate nerves. Can the genital branch be blocked for diagnostic purposes? Depends on where you wish to make a diagnosis. Remember that the only way that has been described in the literature of blocking the genital nerve is in the inguinal area. So that you have the pubic symphysis here, you have the pubic rami here, and what you'd attempt to do, pubic rami here obviously, and what you attempt to do is, using fluoroscopy most of the time, go and put a needle directly on the pubic ramus. And this is an example of it here. It will give you anesthesia in the area of the genital area of the genital nerve. However, where does the genital branch lie? It lies in two areas. There is a inguinal segment, but there's also a preperitoneal segment. There is nothing in the literature that substantiates, when you perform the block as shown here, that there is any medication that gets to the preperitoneal area. Most of the time, this block is performed by pain medicine doctors who are attempting to determine whether there's anesthesia dolorosa or something going on in the perineal area. We don't ask the question what is going on in the preperitoneal area. There is nothing in the anesthesia literature that suggests that the preperitoneal branch is blocked at all. Can iliohypogastric nerves be blocked without affecting the ilioinguinal nerve? No. This is easy to conceptualize. As you all know better than I, that your iliohypogastric nerve runs here by the anterior superior iliac spine, and then you also have your ilioinguinal. Remember that they lie in a plane, in a neurovascular plane, in a transverse section. And the way that an anesthesiologist would attempt to do this is to go approximately a centimeter medial and a centimeter lateral, and then to block the ilioinguinal by touching the anterior superior iliac spine, and the ilioinguinal by appreciating two fascial clicks. Look at the proximity of the iliohypogastric to the ilioinguinal. I would propose that if you give 2 milliliters, or perhaps even 1 milliliter, okay, you've already spilled drug onto the other nerve. So how can you distinguish between these nerves? I don't think you can by the technique. Now, ultrasonography is something that's being experimented with. Perhaps that will be able to give you discriminative blocks, but I don't believe that there are any published studies looking at the use of ultrasonography in any of these blocks, though I know that they're being actively investigated. And last question, at what stage should non-surgical treatment stop? I don't know. I'm not a surgeon. I don't usually tell my surgeons when they should operate or not, because I don't do the surgery. And so I would leave it to yourselves to determine really when you think that it is time to reoperate. Because as I don't do the surgery, I wouldn't presume to tell you when it is appropriate. And I thank you very much for listening.